because it's a little loud out there in the hallway, and I'll let Dr. Peischer introduce our speaker.
I'm really happy and privileged to introduce our speaker this morning, Dr. Arie Perry. Arie was a resident mate of Amy Lowachek's at UT Southwestern in anatomic and clinical pathology, and trained with Dr. Bernd Scheitauer at the Mayo Clinic, one of the most distinguished neuropathologists of the 20th century and early 21st century. And has developed a career to be, I think it's safe to say, the preeminent neuro-oncologic pathologist in the world. Really privileged to have him here. We're also excited to have him here because there'll be a little surprise toward the end of his discussion. I won't give any of it away, but, but you will enjoy it. Anyway, but I really want him to get in. He's going to be speaking today about the integrated WHO CNS tumor diagnosis. And the integrated is really in this era of precision genomics. This means that it is an integrated pathologic and molecular diagnosis, giving us more precision in the diagnosis of brain tumors than we've ever had, and really creating a new era that I think that is spreading to other areas of tumor pathology, where morphology is important, but needs to be correlated with other molecular studies. And we participate very heavily with UCSF, and so we wanted to invite Arie to come and speak. Dr. Perry.
Thank you very much. It's a great pleasure to be here and talk to you a little bit today about some of the really dramatic changes that have been occurring in our neuropathology practice over the last few years and the rationale for those changes. So I have no disclosures. And this was a requirement, so here's some professional gaps and desired results, and I will just let you read that for a few seconds rather than reading it to you. Okay, so now we'll start. So one of the things we do a lot of course, with microscopy or in pathology in general is pattern recognition. And sometimes some of our clinical colleagues tease us about the pattern recognition, but in fact, everybody does pattern recognition, right? And it can be extremely powerful. So when I put up this slide, at least those of you old enough to remember, within a millisecond, your brain told you this is Elvis Presley, right? And you didn't have to do any morphometry, you didn't have to do any DNA tests. It's really remarkable, the thousands of morphologic details that very quickly your brain puts together and tells you this is Elvis Presley. So this is a very powerful thing that we all do, and we all do it every day. Of course, one of the problems for those of you that have a good eye is, in fact, two of these are not Elvis Presley. They're Elvis Presley impersonators. And so while they may look very similar, perhaps they're not quite the real thing. And with tumors, we sometimes see that too. Two tumors may look remarkably similar, and yet the biology is extremely different. So how do we get around that? All right, so the other problem is that we face every once in a while is that sometimes we get mixed or confusing signals with morphology, and we're not quite sure which way to go with some of those signals. So this is another issue that we deal with. And so really over the last 10 or 15 years, there's been a molecular revolution that we are now incorporating into our daily practice that I think helps with some of these issues. To give you one example at least, if you take a single diagnostic entity like glioblastoma, and you do genomic studies on them, and this was from 2012, so it's been a while now, but it still holds true that, for example, in this study, they find that molecularly this isn't one entity, but probably at least 6 entities. They tend to have very distinct clinical pathologic correlations, different ages of onset, different survival patterns, and perhaps we should be treating them differently because of this. And so biologically, they're not really one entity. Now I put boxes around the 4 out of these that actually occur in the pediatric age range to a large extent, and the green boxes are ones where we now have immunohistochemical surrogates for identifying these, and I'll show you what they look like. Now this I know you can't read. This is from the second edition of a textbook that I'm one of the editors for, that's about pattern recognition in pathology, and this is a brand new chapter on molecular pattern recognition. And this is a table, so it shows that we now have about 50 or 60 different brain tumor types with fairly specific genetic signatures. And so this is again why things are moving relatively rapidly, and it's an exciting time to improve our diagnostic accuracy. So a few years ago, before the WHO got together, several of us from around the globe decided we needed an initial meeting to decide, well, how are we going to create the rules for incorporating genetic or molecular signatures into diagnostic entities. And we met in Haarlem in the Netherlands in 2014, and one of the, I think, big takeaways from the meeting was we decided a little bit like the layers in a Google map that you stack on top of each other, we're going to take the different types of information you get out of tissue and stack them on top of each other, or this layered diagnosis, and come up with what's called an integrated diagnosis. So we typically start with histology like we normally do, our impression, what's the WHO grade based on natural history, add the molecular information, put all 3 of these together, and then on the top line, which is of course the most important one, we incorporate all aspects of tissue diagnosis into this integrated diagnosis. Then we had our actual WHO meeting a year later in Heidelberg in Germany, and I particularly like this photo because it looks like we're gazing up into the heavens for divine inspiration, which of course we probably needed. And then we published the WHO in 2016, and really the areas that dramatically changed, and I'll go over this, are the diffuse gliomas, especially according to IDH mutation status. There's a new entity of ependymoma, which I'll show you, and the embryonal tumors, which is especially important in pediatrics, changed quite a bit as well. In addition, we created a new group because we were aware of the fact that the WHOs come maybe every 6 or 7 years, sometimes 10 years, and a lot is happening very quickly in between that. So we need to inform people what those changes are between the WHOs. So we have this group called C-Impact Now, Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy. And you may ask, well, what's the NOW? NOW is not officially WHO. That's what the NOW stands for. But of course, these are many of the same people that are involved in the WHO, and the hope is that those, whatever we adopt will eventually become part of the WHO. And like in the last meeting that we have, it's also not entirely made up of just pathologists, but we have clinical advisory board that includes neuro-oncologists and as well, some neurosurgeons and things like that. Okay. So the changes that I'm going to tell you about are all essentially based on biomarker principles, right? And we know biomarkers come in at least 3 flavors. They can be diagnostic, prognostic, or predictive. And so when we look at these biomarkers, you should ask yourselves, which type of information am I getting from this biomarker? Now, since the WHO is primarily a diagnostic book, we focus the most on the diagnostic biomarkers. But don't worry. Sometimes when I say this to oncologists, they think, well, somehow we're biased against predictive biomarkers. Believe me, I would love to have as many predictive biomarkers as I can. We still use them. It may not be part of the diagnostic line, but we definitely use them. Then there are practicality issues because this is, of course, a system for the entire world, and not everybody has the same resources. So we know, at least in pathology labs around the globe, more than 95% at least have access to immunohistochemistry. So whenever there are immunostains that are surrogate biomarkers, we try to focus on those as well. So to give you an example, this is a new major category, the IDH mutant type of astrocytoma, which has a much better prognosis than IDH wild type. We can actually pick up the majority of these with an antibody against the most common mutation, about 90% of these. And typically they also overexpress P53 and lose ATRX. Of course, the problem with this is, like many things in pediatrics, it's not quite the same as in adults. So this is maybe true only in about 10% or 15% of the pediatric cases. Similarly, now the oligodendrogliomas have to have two molecular parts of their definition. They have to be IDH mutant and show chromosome 1p and 19q codeletion as part of the definition. But again, in pediatrics, this is only about 10 to 15% of what looks like oligodendrogliomas in the pediatric patients. So this is a little bit sticky. So this is some data from the St. Jude group. And in fact, those same types of tumors that we see, or what look like those tumors, the Elvis Presley impersonators, if you will, in pediatrics often have different alterations, and there's a group working on trying to get better integrated diagnoses in pediatrics. The problem is that these oligodendroglioma-like tumors are not a single entity, but several different entities that tend to have these FGFR1 alterations. The astrocytomas, the same thing. They tend to have MIB and MIB-L1 alterations. Glioneuronal tumors, often BRAF alterations. So it's not quite as neat and simple as in the adult cases. So here's one of the other, so the IDH mutant category of these diffuse gliomas, it's a major part. It can be grade 2, 3, or 4, but they have a much better prognosis than the IDH wild type category. There's another mutation that's not nearly as common. Histone 3, so one of the histones in chromatin maintenance, has a specific mutation in lysine 27. And this is highly associated with midline gliomas. So the diffuse intrinsic pontine gliomas that we've been talking about for many years, well over 80% of them have this mutation. Thalamic high-grade gliomas, spinal cord high-grade gliomas, so frequently in kids and younger adults, but it can occur almost at any age. These have this typical mutation and have a dismal prognosis, unfortunately. And so this is, I'll show you in a minute, but this is one of the few cases where we don't actually have to grade these. They're all considered grade 4 by definition. So fortunately, like the case with IDH1, there is now a specific antibody for the mutant protein for histone 3, K27M. And it's highly specific and sensitive. About 20% of them will also have P53 and ATRX mutations, which we can use surrogate markers with immunohistochemistry. But basically, this is the new diagnostic entity, diffuse midline glioma, H3K27M mutant, always grade 4 by definition. We can use another antibody just to make sure this is working, because occasionally between one lot and another, this has some tricky technical issues with it. So we can also use the trimethylated histone 3 tail of K27, and typically it should have the opposite pattern. So if it's gain of the mutant protein, loss of the trimethylated protein to identify this subtype. Yet another one, a little bit less common now. These are mostly hemispheric tumors, mostly in kids and young adults. High-grade tumors with an intermediate prognosis between the other two that I just told you about. And it's another histone 3 mutation that identifies these, but in amino acid 34. And it converts guanine either to arginine or valine. And this is what these often look like. They're often very cellular neoplasms. Sometimes they look very primitive, and almost half of them actually get misdiagnosed as PNET or have been in the past. So it's something to keep in mind for us as pathologists. It looks like a PNET in the cerebral hemisphere of a kid. Keep this entity in mind. And we have now antibodies, commercially available antibodies to these two mutant proteins as well. We actually just combine the two together. But this is not yet a WHO entity. I think it probably will be in the next one. There's now good evidence that this is a biologically distinct subtype. Nearly all of these will have loss of ATRX expression and P53 overexpression, so that's another clue in the differential to these tumors. So here's a fairly recent article, came out almost at the same time or a little later than the WHO, looking at 81 of these patients with this tumor type, and about half of them were called GBM, half were called PNET, and but they tend to have the same methylation profile for all of these tumors, suggesting they are indeed a single biologic entity. They often have PDGFR-A amplification and/or CCND2 amplification. Here's the age range and median, so older kids, younger adults. P53 and ATRX mutations frequently, and certain cytogenetic alterations. MGMT is methylated in about 3/4 of these cases. And the overall survival is not great. About 22 months was the average in this study, but still better than either the diffuse midline glioma or in adults, the IDH wild-type GBM. So we now can put together these kind of vocalgrams that we never had just a few years ago. And we know there's a major group of these gliomas that have IDH mutations. If you superimpose P53 and ATRX, they go down the astrocytic lineage and they can become higher grade over time. If you superimpose 1p19q codeletion and TERT mutation, they go down the oligodendroglial lineage and again can get additional alterations as they become higher grade. We have this major category of IDH wild-type GBM, though probably, especially in pediatrics, some entities, other entities are going to come out of that, including the H3G34 mutant subtype. And we have the diffuse midline glioma H3K27M mutant. Now notice I didn't put oligoastrocytoma anywhere in this chart. And the reason for that is that once you add these molecular markers, you virtually never have something that is an oligoastrocytoma. They'll either have the molecular features of oligodendroglioma or of astrocytoma or one of these pediatric subtypes if you look for it. But this is becoming extinct if you're using the integrated diagnoses. They may look mixed, but molecularly they're not mixed. There are very, very rare cases where one area of a tumor is both histologically and molecularly oligo and another is astro, but those are case reports at this point. So one of the questions I frequently get when I give this lecture is, well, you know, I'm in an area with very few resources. What do I do? This is supposed to be the World Health Organization. Everybody throughout the globe is supposed to be able to use this. So my friend Vin Diesel will tell you the answer is NOS. which of course in Fast and Furious is nitrous oxide, but in the WHO scheme, NOS is not otherwise specified. So this was the way the WHO got around basically when people don't even have the antibodies or any of these resources to identify these, then you add not otherwise specified. So if to me it looks like an oligoastrocytoma and I don't do anything further, I'll put NOS, right? And then if that patient then goes to a big academic center, the oncologist will look at that and say, well, that means that the molecular wasn't done, or the molecular, for some reason, wasn't entirely conclusive. We need to finish those studies and get a better answer before we proceed. So that's the way that we got around that. Now, some other biomarkers that we use that often don't go into the diagnostic line but are very important clinically are BRAF alterations. And that includes the BRAF fusion that's very common but not absolutely pathognomonic of pilocytic astrocytoma. So only about 70% of pilocytic astrocytomas have this fusion, but this could be especially a predictive biomarker because there's data suggesting that MEK inhibitors works on a number of these patients, and especially if it's not surgically resectable or completely resectable. That can be very useful. Unfortunately, we don't have any immunohistochemical surrogates for that. We also look for BRAF V600E mutations, especially in many of our pediatric cases. And again, it's not absolutely diagnostic. There are certain diagnostic categories where it's certainly much more common, so it can be helpful. But it can be also a predictive biomarker. Again, either BRAF inhibitors or MEK inhibitors can be useful in those cases. So we do have an immunohistochemical surrogate for BRAF V600E, and here's an example in a ganglioglioma. The one thing for the pathologist to note is that sometimes these are expressed at very low, the mutant protein is expressed at very low level except in the ganglion cells. So if you have a particularly ganglion cell poor example, you may have to look around to see the positivity. So spend a little time on it. If it's not clear cut, we'll go to sequencing. Sometimes the stain is a little finicky as well. But I did want to mention that if you add on top of BRAF V600E mutation homozygous deletions of CDKN2A, that combination now becomes almost pathognomonic of another tumor type, pleomorphic xanthoastrocytoma, or PXA. So there have been cases where this was in the differential with other tumors, and this combination is extremely useful for suggesting it is in fact a PXA, which is grade 2 in the WHO, or can be anaplastic grade 3. All right. We now know a number of these tumors, especially pilocytic, one of the most common tumors we see in pediatrics. Essentially, all of them will have some alteration in the MAP kinase pathway. The most common, as I mentioned, is this fusion, but there's many others that can be identified as well, and you can see the list here, some of which have targeted therapies, others not so much. We often do look for the most common one using FISH or next-generation sequencing, but it doesn't pick up all cases of pilocytic astrocytoma. So now let's talk about another major glioma subtype, the ependymoma. Ask the same question: is this biologically one disease? And almost always when you look at the genomic studies, the answer is no, it's multiple diseases. So here's a big study that was done a few years ago, and it turns out ependymomas have at least 9 subtypes, 3 at each major location. So 3 supratentorial, 3 posterior fossa, 3 spinal. Fortunately, most of them have a very favorable prognosis with 2 exceptions. One is a supratentorial ependymoma with RELA fusion, and this is now a new entity in the WHO. And I'll show you how we pick that up. And the other is the posterior fossa molecular subtype A, which tends to be a lot more aggressive than the type B. Okay. So for the supratentorial ependymomas with RELA fusion, we often do have a morphologic clue. It's not 100%, but many of these cases have clear cell morphology. So when we see the clear cell morphology with branching capillaries in the tumor, clear halos, typical cytology that often actually looks a lot like oligodendroglioma. Then we think about this subtype, and we do have at least one surrogate marker, L1-CAM. There's actually another one now that the Europeans use more frequently, and we're probably going to switch soon as well, and that's the P65 RELA. It's a more direct correlation with this RELA fusion. And then if we really want to prove that this is indeed the RELA fusion subtype, we'll do next generation sequencing, or certainly you could do a fusion assay like you do in sarcoma work, or sequencing looking for this specific fusion. Now it's become a little bit controversial because it's not nearly as clear as it was before. Are these really more aggressive than the other supratentorial ependymomas? So sometimes it seems clear at the beginning, and then more people publish, and so it's still not entirely clear. So it turns out at the time of the WHO, there was not a surrogate marker for the posterior fossa type A, so that's not technically a subtype in the WHO. Again, I suspect maybe in the next WHO it will be. It was hard to identify because it was mainly originally identified by epigenetic pattern. So methylation profiling was one of the main ways to identify this. It tends not to have any specific mutations, any specific copy number alterations. So it's mainly epigenetic alterations, and now a couple of groups have shown that in fact this is a highly sensitive and specific marker for this subtype, that trimethylated histone 3 tail of lysine 27 normally is expressed in all nuclei. In the PFA ependymoma, essentially always you have loss of expression. So this is a PFA ependymoma, this is a PFB ependymoma with retained expression. If you want the cheapest way to identify this, look at the patient's date of birth, because the PFA ependymomas are the youngest patients. They tend to be the infants and young kids. The PFB ependymomas are usually older kids and adults. So it's not 100%, but you can often predict which way it's going to go just by the patient's age. So embryonal neoplasms, that's been revamped quite a bit since the last WHO. And I'll go through some of the alteration, or some of the changes. So like glioblastoma and ependymoma, people have been doing genomics on medulloblastomas, and the consensus a few years ago was that there's at least 4 major subtypes with some very distinct clinical differences. WNT have the WNT group has a nearly 100% survival in these patients, so there's now initiatives to reduce the aggressiveness of therapy, so avoid side effects, things like that. Unfortunately, only about 10% of the cases fall into this category. Sonic hedgehog tend to occur mostly in infants and adults, and they have some distinct features and can be subdivided further by P53. And group 3 and group 4, unfortunately, are often hard to distinguish, and so at least at this point, they're often lumped together. And I'll show you some examples. So this is work by David Ellison's group at St. Jude several years ago. We were peripherally involved in this as well, looking for surrogate markers to identify these 4 subtypes. And again, we were, as I was mentioning, group 3 and 4 are hard to separate, so this term came out, non-WNT, non-sonic hedgehog, or could be group 3 or 4. And so we can do immunohistochemical screening. It's not perfect. We've had a few mistakes, but most of the cases you can predict pretty quickly with immunohistochemistry, and I'll show you what that looks like. So for the WNT group, our main marker that we use is beta-catenin, And this is actually a negative. So cytoplasmic staining is normal in medulloblastomas and many other tumors. We're looking for nuclear translocation of the Wnt. That tells you the Wnt pathway is activated. And I'm showing you my best case, where lots of nuclei are positive. For me, the problem is in some of these cases, it may be 1% or less of the nuclei that are actually staining positive. So this is a tricky antibody. And for that reason, people have been looking for additional markers, and we've recently added these two. None of them are absolutely 100% sensitive or specific, but when you add all three of these together, we're now doing a lot better. ALK and LEF1. Most people have from hematopathology already in their lab. So you can use other things that tell you this is Wnt. One of the big things is monosomy 6. So you can either do FISH to look for monosomy 6. You can do CGH or array CGH. We get a copy number plot with our next generation sequencing, so that's very helpful, and you see the monosomy 6. That tells you this is almost certainly the Wnt subtype. Sonic hedgehog, we often get a clue because the majority of these are desmoplastic nodular medulloblastomas. So on morphology, we can already predict in maybe 90% of the cases this is going to be sonic hedgehog activated just on the H&E. We can already tell that. But it's, again, not perfect. So we have a downstream marker of sonic hedgehog activated that most people now use called GAB1. And you can see here's an example that's positive. And for both Wnt and sonic hedgehog, there's another marker, YAP1, that's typically positive. So we add that marker for increased confidence. And the other thing I should mention with especially sonic hedgehog, but all medulloblastomas, you'd be surprised how many of these arise in hereditary predisposition syndromes, but especially the sonic hedgehog and especially the youngest patients. So very frequently, especially in infants, we'll find germline mutations in SUFU, less often patched, and some of the other medulloblastomas will have other alterations as well. So we try, at least at our place, as often as possible to run our next generation sequencing not just on tumor, but on germline as well. That obviously that requires a consent from the patient's family to do that. But it's been surprising how often we find a hereditary predisposition syndrome. The other thing this tells you, if you're looking at specific mutations, those with patched mutations tend to be responsive to smoothened inhibition, smoothened inhibitors. Those that are other alterations like SUFU that are further downstream tend not to be responsive to these inhibitors. So there's, again, some predictive value in knowing which mutation is associated with the sonic hedgehog pathway. So life gets more complicated, and people discovered that actually within the sonic hedgehog medulloblastomas, most of them are p53 wild type and have quite a favorable prognosis in the infants and kind of standard risk in the adults. But if you superimpose p53 mutations and or overexpression, these are highly aggressive tumors now all of a sudden, and require a very different therapy. So we add p53 to our immunohistochemical panel. Many of these we also get a clue from morphology because they often have the anaplastic or large cell morphology, which we've known for many years is associated with a much more aggressive biology. And here's an example, p53 overexpression. And again, many of these, when we run the germline, these tend to be in between. So these are kids, not infants, not adults, but in between. And many of them either have Li-Fraumeni or Fanconi's anemia as the predisposition syndrome. So just keep these in mind, since it has implications for really the entire family. So both in Fanconi's anemia and Li-Fraumeni, they often have a very unstable genome, and you see these wild copy number plots as you see here. Now, unfortunately, I kind of alluded to this, but 60% of all the medulloblastomas we see are not Wnt or sonic hedgehog. They're in this other category. They're usually classic on histology, and they're neither Wnt nor sonic hedgehog. And so it's a big group of tumors. They will be identified on immunohistochemistry by being negative for YAP1. And here's the internal control in endothelial cells. The tumor cells are negative. So we know this is non-Wnt, non-sonic hedgehog. And both group 3 and group 4 often will have other clues like isochromosome 17q. Doesn't tell you which group that's in. There are other clues like MYC amplification is typically group 3. But you know, the splitters are winning out over the lumpers over time. And so the more recent the articles you look, now there's this group from Sick Kids in Toronto and many times also the Heidel group, people from Germany, now say there's 12 groups, 12 subtypes of medulloblastoma. I think this is going a little too far. I think statistically it's very hard to segregate medulloblastomas into 12 separate distinct groups. But if you want to go crazy, you can subdivide these into 12 groups. All right, so another embryonal tumor type that we've known is highly aggressive for a long time, that's the atypical teratoid rhabdoid tumor. These are almost limited to infants, have a horrible prognosis, as you can see here, although I've now been told by pediatric neuro-oncologists there's a lot of success stories. So the more recent highly aggressive therapies, we're seeing a lot more survivors. That's what I heard from Toronto and others. So maybe it's not quite as bad as it used to be, still highly aggressive though. The WHO now demands that you prove that it has inactivation of one of two genes before you can call this an ATRT. By far the most common, over 99% of these cases, inactivate the SMARCB1 gene, which encodes the INI1 protein. And so we've had this immunostain now for a long time. And we can see the internal control here with endothelial cells, loss of expression in tumor cells. Much less frequent is loss of BRG1, and these are rare cases. But in both cases, you can also have familial tumors with germline alterations in either the SMARCA4 gene, which encodes BRG1, or the SMARCB1 encodes INI1. So if you don't have that, you have to call it a embryonal tumor with rhabdoid cells. And we don't know quite what those are at this point, but you have to be descriptive. One of the things that changed is ependymoblastoma used to be a diagnosis. In fact, most of those now belong to a new entity, a new tumor type, but not all of them. And that is this embryonal tumor with multi-layered rosettes. These are what were called previously ependymoblastic rosettes. They're true rosettes, multi-layered. This is a tumor that often has a combination of focal ependymal differentiation, as you see here, and neuroblastic differentiation with a lot of neuropil, some neurocytes, even sometimes ganglion cells. So it's kind of in between neuroblastoma and whatever an ependymoblastoma is. And they have a very distinctive genetic signature, amplification of a microRNA cluster, or MC, on chromosome 19 that you can pick up again either by FISH, that they often do at St. Jude, or on our next generation sequencing panel, we can pick up the amplification here and make this diagnosis. So embryonal tumor, multi-layered rosettes, C19MC altered is a new type of embryonal tumor. Very aggressive, mostly infants, in many ways a lot like ATRT in that respect, but a different biologic background. We have a immunohistochemical marker. It's not perfect, but it's quite good. And this was a study from a few years ago looking at Lin28A in peanuts, and those that were positive, as you can see here, have this horrible prognosis. So this is our marker for picking up embryonal tumor with multilayered rosettes. So another big thing that changed in the last WHO, so there's no such thing as peanut anymore. Primitive neuroectodermal tumor, and the reason for that is people felt that was a non-specific term. It's been overused, and so we'd rather people try as hard as they can to put it into one of these other categories if you can. Now, you can't always, right? So essentially the WHO replaced one garbage term with another, and that is CNS embryonal tumor NOS. So basically what we used to call peanut is now embryonal tumor NOS. The hope is that as we identify more and more subtypes, this will eventually disappear, and we won't have anything that's NOS in the future. And here's a little bit of proof of that principle. This was a huge study from the Heidelberg group, cast of 100, as you can see. I think I'm somewhere in the middle there. But basically, they got all their friends from around the world to send them what had previously been called CNS PNET. So about 300 cases or so. And they did genomic studies on these cases, and in fact found that most of them could be reclassified as other entities. So many of them were glioblastomas or other high-grade gliomas, ATRTs, ependymomas, a variety of other entities. But in fact, they found 4 subtypes that seemed to be biologically distinct or molecularly distinct that hadn't been identified previously. They're all relatively rare. And they proposed these 4 new names for these subtypes. This was after the WHO came out, so again, these are new embryonal tumor subtypes, at least in most cases, that may be part of the next WHO. So you can see how things are evolving very quickly. And again, the C-Impact Now is the one that's mainly dealing with these as quickly as we can. There have now been about 3 publications already since 2016 from the C-Impact Now, and there are more that people are working on, including the pediatric group within the C-Impact Now. So I know I gave you a huge amount of information in a very short amount of time. One of my biggest hobby and sometimes even semi-profession has been music for many years. And a number of years ago, I started teaching the medical students by always adding a song at the end to emphasize the teaching points of the lecture. So a couple of years ago, I was with this men's a cappella group, and we were working on Bohemian Rhapsody by Queen. And I convinced them to, I rewrote the words and convinced them to record a brain tumor rhapsody with me. I'm the only pathologist in the group, so they all had to learn the terminology. But we're now going to reinforce all the concepts I just gave you with music. And don't worry if you like it, it's on YouTube. As far as I know, still the only brain tumor rhapsody on YouTube, so there's no other competition. And it has multiple harmonies. If you want to sing along, sing any harmony, high, low, middle, anything you want. But I'll do the melody for the first part and one of the higher parts towards the end, but feel free to join in it. Is this an astro? Is this an oligo? Some cells are rounded, but then others just aren't so. Open your eyes to future pathology. I'm just a boy, I have no NGS. I can integrate my immunos with histology, don't you know? Try on my own marker, it will make you smarter to me. Can't you see? pass this vital test. Dear cow, strong B53, with loss of nuclear ATRN. Dear cow, no deletions did we find on fish exam for oligon and droglioma, diffuse astro at all time is my final diagnosis. Another subtype we see includes mutations of H3 to 27 M4C. Midlife, high-grade astros, and mostly young patients. Gotta find a way to beat this travesty. Dear cow, with G34 instead, cerebral GBMs aren't so aggressive as the older GBM. Most genes are wild type, with turn mutations of the motor region. Rapid cells, do you see the pink belly? Pathologic and it's frightening, very, very frightening. Whoa! ATRT! ATRT, don't you know? Oh, no, no! Oh, he's just a poor boy with a bad tumor. He's just a poor boy with a bad tumor type, sparing his life from his monstrosity. Brian, no tumor type, how to diagnose it? B1, no! Immunonegative. Negative. B1, immunonegative. Negative. B1, immunonegative. Negative. 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 Oh, no, 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 no. I1, don't you know? Loss of expression means ATRT to me. references.
Well, I think this was a pediatric grand rounds first. That was excellent. Any questions for Dr. Perry?
When the tumor is resected or goes away and then comes back, do you rebiopsy it? And does it gain new mutations and change subtypes? Change your
Yeah,
the
great
tumor?
question. So certainly it does in some cases. And tomorrow with a smaller group, I'm going to talk about our next generation sequencing and when we use that. But essentially, for our in-house cases, we use it for all our pediatric malignancies and often for some of the benign ones as well. So certainly you can see progressive changes. Sometimes you can see changes induced by the therapy itself. There's a particular signature with temozolomide damage that, especially more so in adults, but lower grade astrocytomas that convert to higher grade have this particular signature. So we certainly can see progression. Sometimes they don't, and they're identical to what they were previously. But a lot of times, if the oncologist has tried several therapies, they will want it to see if there's anything new that they can target, or if there's maybe something that's come up that explains resistance to the prior therapy. So we're doing some of that. I don't think we're 100% there yet. And we still don't have a lot of feedback of how well the targeted therapies, when they use them, are actually working. I think we need more time and more data to figure that out.
All right, first thing, best summary I've ever seen of any talk ever, no doubt about that. So with regards to, grade 4 tumors that behave with treatment far, I don't want to say more in a benign manner, but in a far more favorable manner, based on their molecular, based on their molecular analysis, or their molecular identity, I guess you could say, or and I think of things like, group 1 medulloblastomas. I also think of things like, IDH mutant, anaplastic astros are going to behave more like a grade 2, whereas if they're wild type, they're going to behave more like a grade 4. So is there any movement that you see that we're going to be taking these things into consideration? I mean, the neuro-oncologists already do, but taking into consideration with the WHO grade we assign.
Yeah.
Are we going to, because it's a histologic grade and that's completely fine, but are we going to start melding not just the diagnosis, but the grade itself?
So great question. That was something we debated quite a bit at the meeting in Harlem.
Mhm.
Should there be a GBM WHO grade 3 in the certain molecular?
Right.
And I think most of us, me included, thought that would be way too confusing to try to do that. And these original WHO grades were based on natural history for a group of patients. And we almost never get natural history anymore, right? Because you wouldn't want to, you got to treat. So I think we're sticking with the original WHO grades of what we think is the natural history if you don't treat a patient like that.
Mhm.
And I think that's been around long enough that it's less confusing than trying to change that. So we just try to make sure people know, yes, a GBM that's IDH mutant is still WHO grade 4. It tends to have, a much better prognosis and much more like a grade 3 or even a favorable grade 3
Yeah.
than other grade 4 tumors. So,
Okay. All right. So we're relying a lot on neurosurgeons and neuro-oncologists to understand this stuff as well.
yes, I think they can do that.
Yeah, I think they can too. All right.
We can teach them if they don't.
Thanks for being with us, Dr. Perry, and thanks for doing our pathology on all of our pediatric CNS tumors, which a lot of people don't know. Who is actually in charge of determining when another WHO classification system will come out? Is there a group within WHO? Is it this group of individuals such as you, who is
Yeah.
a part of the actual body who determines the changes? Obviously, the science dictates how quickly it happens, but
Yeah. That's a
insight into that?
great question, and it was a major part of why we put together the C Impact Now group. So, in actuality, the latest WHO is not a new edition. It is a revision of the fourth edition. And the reason for that is, the global WHO that covers the entire body goes through you can't have a new edition for one organ system until all the other organ systems have finished. So there were still people working on the fourth edition of other body organ systems while we were petitioning to have a new WHO. So both HemePath and us basically petitioned and published a revised version of the fourth edition. It's not really a fifth edition. There is a new head of the IARC in Europe, in France, I guess it is, who's very ambitious right now and wants to greatly accelerate the time to publication of these groups. So I don't know that I believe it. He says, for us, that's supposed to be 2020. I find that incredibly hard to believe that we'll be ready to publish the fifth edition already by 2020, but maybe. We'll see. So that's the person in charge. I think there's a committee that decides who's going to be, the main person for that fascicle or that WHO, and it's been David Lewis for the last one or two. I don't know whether he'll be the one in charge or if not, who it will be. So that's as far as I know.
I saw hands, I think, scratching heads over here. No questions? Anyone else? No? Okay, well, join me in thanking Dr. Perry.